All right. Our second speaker is Dr. Jack Burke. He's currently a professor of pharmacy practice and the Associate Dean for Postgraduate Education at the St. Louis College of Pharmacy. He earned his BS degree in pharmacy from the University of Missouri, Kansas City, and his Doctor of Pharmacy from the University of Texas. He completed his clinical pharmacy residency at Truman Medical Center in Kansas City, Missouri. Dr. Burke is a board-certified pharmacotherapy specialist and has been a clinical practitioner and faculty member for over 25 years. Please join me in welcoming Jack Burke as he talks about nephrology.
Thanks, Brian. It's a pleasure to be with all of you today. I'd especially like to welcome the people in the back of the room who I think are sitting on the California-Arizona state line. It's so far back. But anyway, I'm pleased to talk with you today. Sort of like Brian's presentation, we have quite a bit to cover. I don't have any conflicts of interest related to this topic. The learning objectives are on page 256 of the workbook, but this sort of outlines the topics that we will talk about. We'll talk a little bit about acute kidney injury. There is some sections in the workbook on drug-induced kidney disease, and we're primarily going to talk about contrast-associated nephropathy. We'll then talk a little bit about chronic kidney disease. Complications, particularly, we'll talk about anemia and mineral bone disease, and then we'll finish up with a case on drug dosing in kidney disease. Just to focus you a little bit, most of the content that relates to the pharmacotherapy exam will focus on patient-specific pharmacotherapy, which is domain 1, as you might expect, but I have one question in there that focuses on domain 2. So the first case, which is on page 261 of your workbook, is a 48-year-old man who came in with an acute myocardial infarction. He has a history of diabetes, hypertension, and smoking, and he's on a number of medications. When he came in, his baseline serum creatinine was 1 milligram per deciliter, but over the past 24 hours, his kidney function has declined, so his BUN is 20, and his serum creatinine is now 2.1, so it's more than doubled. His urine shows muddy cas, and he's been anuric for the last 6 hours. Currently, his blood pressure is 110 over 70, but he has significant peripheral and pulmonary edema. So our question is, what's the best assessment of this patient's kidney function? Okay. All right, so I see a few answers. I agree with those. And what I'm going to do, like Brian, we'll talk about the topic and then we'll come back to the question again. So acute kidney injury, this patient is obviously experiencing, is an acute decline in kidney function. That is often over a period of hours to days, but can even progress more slowly over a period of weeks, resulting in the accumulation of waste products. Often we see an increase in BUN, and often there's an increase in volume as well. The Acute Kidney Injury Network has 3 criteria that they use to classify somebody as having acute kidney injury. It can be as minimal as a 0.3 milligram per deciliter increase in serum creatinine, or an increase from baseline of more than 50%, or if you look at urine output, less than a half a mil per kilogram per hour for more than 6 hours. And we're going to look at the next slide, the rifle criteria that are sometimes used to stratify or classify acute kidney injury. So the 5 classification rifle standing for risk, those people who are at increased risk for acute kidney injury, those who have expressed some injury, those with failure, loss, or end-stage disease. So if we look at the GFR criteria, this particular patient would fall in the injury category because they have had more than a 2-fold increase in their serum creatinine from baseline. So it went from 1 to 2.1. If we also look at urine output, they are anuric, but they haven't had it long enough in order to meet the criteria for acute kidney failure. If it persists for another 6 hours, then we could reclassify the patient. But clearly the patient has acute kidney injury. estimating kidney function can be a little challenging in acute kidney injury. Most of the equations that we use on a regular basis really assume a stable serum creatinine. They're based on steady-state formula calculations, and so that if the serum creatinine is rising, you would actually overestimate what the patient's GFR is based on that unstable serum creatinine. So those aren't very helpful. There's a few other equations like Brader and Jelliff that may be a little bit more accurate but aren't well tested. If a patient is non-oliguric, unlike this one, then you can actually do a timed urine collection and actually measure creatinine clearance, and that may give you something a little bit better. In that case, you would just sort of average the serum creatinines over the urine collection time. So, anybody want to take another stab at the answer here after our discussion? Okay. So again, yes, because this patient is anuric, we can make the assumption that really they have no glomerular filtration going on, so less than 10 mils per minute, or very minimal. So anuria really implies that there's no GFR. Okay. So what do you think is the most likely cause of this patient's impaired kidney function? We're going to talk about classifying it because it may help us guide therapy. What are your thoughts? See some red, some blue. Okay. All right. So let's talk about this. So this is table 2 on page 264 in the book, and it looks at information regarding the patient's history, physical findings, and laboratory data that can help you classify whether the patient has pre-renal or a functional decline in their kidney function. They have intrinsic renal disease, that may either be ATN or acute interstitial nephritis, or whether they have some post-renal obstruction. So let's look at a few of the things that were present in this case. First of all, the patient is on a nonsteroidal anti-inflammatory agent, although low-dose aspirin, but they're also on an ACE inhibitor. Those can interfere with the normal hemodynamic regulation of glomerular pressure, and so can either cause a functional acute kidney injury or may predispose to patients with other conditions developing ATN. Although it's not absolutely clear from the case, perhaps you'd like to know what the patient's blood pressure is. The fact that they developed pulmonary and peripheral edema suggests that they got a significant amount of fluid, even though their blood pressure is restored at this time. So I have some concerns about whether this patient had some renal hypoperfusion following their acute MI. Their BU to serum creatinine ratio is normal. It's the 15-to-1. If it's greater than 20-to-1, usually suggests pre-renal azotemia. But if there is a decline in kidney function related to a decrease in GFR only, then you tend to see a proportional increase in the BUN and the serum creatinine, so that stays at the normal range of 10 to 15-to-1. This patient does have urinary CAS, which suggests some acute tubular necrosis, which results in those CAS being present in the urine. The patient is not volume depleted. There's no evidence of dehydration on physical exam, so again, not suggesting pre-renal azotemia. So we have a little bit of conflicting information, but probably leaning towards intrinsic renal disease, particularly in the setting of acute myocardial infarction. One of the things that can be useful to help you distinguish pre-renal azotemia from intrinsic renal disease is to look at the urinary sodium concentration and fractional excretion of sodium. So this equation here, which is on page 265, looks at how you calculate it. It's really the clearance of sodium divided by the clearance of creatinine. Because both are spot checks, you don't really need a timed collection in order to do this. If the fractional excretion of sodium is less than 1%, that implies more than 99% is being reabsorbed. And that's consistent with prerenal azotemia. Activation of the renin-angiotensin-aldosterone system increases sodium reabsorption so that the FeNA goes to less than 1%. A fractional excretion of sodium of more than 2% is consistent with intrinsic renal disease, and the tubular damage is impairing sodium reabsorption, so it's high. So this can be very valuable in helping you distinguish prerenal from intrinsic renal disease. Would you like to revote? See if we get any more votes this time. What do you think? I sort of tipped my hand, didn't I? Suggesting that it is, yes, B, intrinsic renal disease. Now, unlike what you'll see on the pharmacotherapy exam, this might be considered a trick question. They usually vet those questions well, so they're not meant to be tricky. This one, I have the advantage of talking you through it, so I can be tricky if I want. So which medication is best to discontinue because of its potential adverse effect on kidney function? I see some A. I see a D. A couple of C's. Actually, the answer is A. Right? Both nonsteroidal anti-inflammatory drugs and ACE inhibitors, or ARBs, are important in maintaining glomerular filtration pressures, and disruption of either of the prostaglandin or angiotensin II production can interfere with that normal regulation. Sometimes people think that metformin might be contraindicated because of it adversely affects kidney function, but really we really worry about the risk of lactic acidosis with it. So it needs to be discontinued, but not because it adversely affects kidney function. And lastly, the low-dose aspirin that this patient is getting is likely not to produce enough inhibition of prostaglandin secretion to interfere with kidney function. So the answer A. Which intervention is most appropriate to add at this time? What do you think? I'm sure it was funny, but I couldn't hear it. Okay, I'm seeing some green answers. Okay, so let's talk about our management of the patient with acute kidney injury. Unfortunately, there's not a whole lot we can do. Prevention is the most important thing, avoiding nephrotoxic drugs. So particularly this patient who is experiencing some injury, we're going to try and avoid at all possible other drugs that may worsen kidney function as well. You want to maintain adequate hydration, and there's a number of ways that you can sort of calculate a patient's fluid requirement, but for an adult, average fluid requirements is about 2 liters per day. Isotonic saline is very good at maintaining perfusion, stays in the intravascular space, and so it's a good choice for somebody where you're trying to give fluid to expand and improve tissue perfusion. And then we'll talk about some drug therapies to decrease the interest of contrast-induced nephropathy. We'll talk about that in a few minutes. The treatment and management of established acute kidney injury depends upon the circumstance. If you have prerenal azotemia, your goal is primarily to improve renal hemodynamics. So again, normal saline if they're volume depleted, manage their blood pressure, again, to increase perfusion, and blood products can be used if the patient has a decreased oxygen carrying capacity. So if they're anemic, on top of that, maybe they had blood loss as the reason for their hypovolemia. Post-renal azotemia, it's primarily about removing the obstruction. So if somebody has bladder outlet obstruction, perhaps putting in a urinary catheter to relieve that obstruction may be enough in order to restore kidney function. Treatment of intrinsic acute kidney injury, there's no real specific therapy. Again, try and eliminate the causes, avoid additional insults, maintain normal fluid balance. So if the patient's having hyperkalemia as a result, you're going to try and treat that. Nutritional support is important, but there aren't any specific recommendations for that. Loop diuretics are not beneficial in prevention of acute kidney injury. And I've got in a few places some guidelines. The grade 1 recommendations are really recommendations, things that you probably should do. The grade 2 are suggestions, which you could do. And then the strength of the evidence is rated A through D, A being the strongest evidence. So not using it for loop diuretics for prevention of acute kidney injury, and not using them to treat it, except if you're trying to manage hypervolemia. So it's not going to improve their kidney function if you give them a loop diuretic in the setting of acute kidney injury, but it may be helpful in managing the hypervolemia and making it overall easier to manage the patients. There's a number of other drugs that have been used over time. Phenoldiprem, I remember low-dose dopamine being used to try and improve renal perfusion. That should not be done. Necertide, IGF, none of those drugs are recommended. In fact, they're recommended to not be used in the setting of acute kidney injury. So which intervention do we want to use at this time? The answer is furosemide. This patient probably doesn't need normal saline because they've probably gotten some fluid. That's why they have hypervolemia, the pulmonary vascular congestion, the peripheral edema. Thiazide diuretics are probably not going to give you enough sodium excretion because they're working in the distal tubule. You're not going to get enough sodium excretion to get a significant diuresis, particularly in the setting of acute kidney injury. So we're going to use a loop diuretic like furosemide. Again, fluid restriction is not going to be very helpful in and of itself for managing this patient's hypervolemia. Okay. Monitoring patients can also be important in kidney disease. So let's look at case questions 5 and 6. Here we have a 67-year-old man, was referred for intermittent chest pain. He has diabetes, hypertension, and category G3A, chronic kidney disease, and we'll talk about that in a few minutes. And he's going to undergo a cardiac catheterization. He has a baseline serum creatinine of 1.8. So what's the best choice for hydration in this patient? I see some Bs. Yeah, mostly Bs, right? So we're really talking about how should we manage fluid in the setting of a patient who's going to get radiocontrast dye. We really worry about exposing these patients to these very hypertonic solutions. The regular contrast dye can have osmolalities approaching 2,000 milliosmoles per kilogram. The low osmolar agents are really in the 600 to 800 range, and it's only the isoosmolar ones that are down closer to 300. But when you give these, you get an osmotic diuresis, can also cause some tubular damage and some tubular proteinuria. You'll see the serum creatinine begin to rise within about 24 hours after administration of the dye, and it can peak within 2 to 5 days. About half of the patients will develop oliguria, and some will require dialysis, at least for a transient period of time. This is the risk factors for contrast-associated nephropathy, and I've bolded the ones that are present in our patient in the case. They have pre-existing kidney disease, which again is defined as either a creatinine greater than 1.5 or GFR less than 60, diabetes, volume depletion. We don't have a lot of evidence that they're necessarily volume depleted, but they are on a diuretic, and so we want to make sure that we adequately hydrate them. And then you worry about the dose of the contrast dye. And oftentimes cardiac catheterizations result in a higher contrast load, and so maybe more likely to cause acute kidney injury than some other radiographic procedures. But volume expansion is really what you're trying to do. You can use isotonic saline, so normal saline, or isotonic sodium bicarbonate. The guidelines really say using either one is okay. There's sort of inconsistent benefits, so you could use either one as long as it's isotonic. It's best to begin this before the procedure, so 6 to 12 hours, so that they're well hydrated and have good urine output. For somebody who has more advanced kidney disease, you can try and reevaluate whether maybe there's another diagnostic procedure that can be done to avoid the dye. Stop diuretics, stop other nephrotoxic agents, and again, if you can use a low osmolar or isoosmolar agent, that can be better for those patients who are at increased risk. The other thing that sort of comes up as a controversial topic is N-acetylcysteine. Sort of the bottom line is that the data is inconsistent. It's suggested that you may use it in combination, but it's the IV hydration that's most important. Again, there are a number of other things: ascorbic acid, theophylline, phenoldiazepam, and prophylactic dialysis or hemofiltration. None of those are useful in the prevention of contrast-associated nephropathy. So really you're talking about using fluids. In our choice, we said we wanted to use an isotonic fluid, and so normal saline is our choice. Again, you're going to get more distribution of either half normal or D5 half normal outside of the vascular space, so you get less volume expansion with either of those. And patients, even with good oral intake, are probably not going to take in enough fluid to maintain adequate tubular flow in order to prevent the contrast. So let's talk about monitoring for a second. When's the optimal time to reevaluate kidney function to assess for possible contrast-associated nephropathy in this patient? So how long after giving the dye do we want to reassess it? Okay. I see a few different ones. Mostly I see B. I think the concern would be about doing it 6 hours, probably not a long enough time for the dye to have caused acute injury, and probably aren't going to see a significant or measurable change in the serum creatinine. 4 days is way too long, and 7, hopefully, if they did develop acute kidney injury, that it's actually improving. Okay. So case 7 through 9, I think we're talking now about chronic kidney disease. So we have a 55-year-old male, hypertension, newly diagnosed with type 2 diabetes. Those topics seem to keep coming back up. Denies alcohol use but does smoke. He's on atenolol. His blood pressure is 149/92. Albumin to creatinine ratio is 400 milligrams per gram. Recent serum creatinine 1.9, which is consistent with what he had 3 months earlier. And his estimated GFR is 50 mils per minute per 1.73 meters squared. So the question is, what's the best assessment of his kidney disease based on the KDIGO criteria? So G2, 3A, 3B, or G4. Okay. See a few answers, but let's talk about this. There are actually a couple of different classification schemes. The National Kidney Foundation's guidelines for classifying chronic kidney disease first focuses, if you're going to call it chronic, you want to know that there's persistent kidney disease for at least 3 months, and that they have either some indication of kidney damage, most likely proteinuria, or a GFR less than 60. And their staging scheme goes from 1 to 5. in which either patients are at risk or have stage 1 with essentially normal GFR more than 90, or down to as much as having end-stage disease or kidney failure with a GFR of less than 15. One of the issues I think that had with this is that many of the patients in stage 3 represent a heterogeneous population, so that those patients with better renal function in stage 3 had fewer complications than what you might see in somebody with more advanced. So the KDIGO categories really took the National Kidney Foundation's guidelines and broke up stage 3 into GFR, and that's what the G stands for, G, 3A, and 3B. So we have, again, still that same 30 to 59 mils per minute range, but 3A is 45 to 59. And so our patient fits into that category. The other thing that KDIGO does is they actually have categories for albuminuria. As Brian mentioned, normal albumin to creatinine ratio is less than 30, and if somebody has kidney disease, you would still call them, even with that sort of normal to mildly increased albumin to creatinine ratio. They categorize that as A for albuminuria level 1. 30 to 300, the old microalbuminuria term, is not used, and we call that A2, and then A3 is anything greater than 300. One of the things that I added on there is also be aware that those patients who have more than 3 grams per day of proteinuria are really classified as having nephrotic range proteinuria. Those patients are more likely to have significant hypoalbuminemia and develop significant peripheral edema because of the decreased oncotic pressure from the low serum albumin. So those patients may need a different approach to treatment altogether. So assessing chronic kidney disease or kidney function in the setting of chronic kidney disease is important. You don't want to use serum creatinine as the only factor because there's a number of things that can influence the production of serum creatinine: age, sex, muscle mass. Most of the laboratories now use a standardized assay, so it's a little bit easier when comparing from one site to another, but it's about 5% lower than what some places had on the other one. And then when we measure it, you can measure it through urine collection. There's a lot of logistic difficulties in making sure that you get a full collection if you're going to do that. Where that really might be valuable in taking that extra effort to get a good assessment is those patients who are vegetarian, so they have lower protein intake, so are going to have less creatinine excretion. They might have lower muscle mass, or patients who have had amputations, really where the standard equations aren't going to give you a good assessment of muscle mass. So those are times when you might think about doing that timed urine collection and actually measuring creatinine clearance. Again, Cockcroft and Gault is often used, but it overestimates GFR and may even be less accurate with the new standardized serum creatinine measurements. Most people, I think, get GFR values through the MDRD study equation. That works pretty well. And then, does anybody use the CKD EPI formula? You'll see that sometimes used. And there's different formulas that are going to be used if you're taking care of patients in the pediatric population. But if you're looking for the pediatric specialty exam, I think that discussion is down the hall. So, again, looking at the KDIGO criteria, how are we going to assess this patient's kidney function? Okay, right. So we're back to, category G for GFR, 3A, and that corresponds to a GFR of 45 to 59, so to the higher end of that stage 3 that we had from the National Kidney Foundation. Now here's a bonus question, no extra charge for this one. It's not, it's in the slide deck, but it's not in the workbook. How would you categorize this patient's albuminuria? Okay, seeing a lot of green, so that's correct. Because this patient's albumin to creatinine ratio is greater than 300 milligrams per gram, we're going to say that they have category A3 albuminuria. Okay. Question number 8 is on page 274. Is assuming the non-pharmacologic approaches have been maximized, what action is best to limit progression of this patient's kidney disease? I think Brian set us up for this pretty well. But let's talk about that in terms of managing and slowing progression. Brian alluded to this as well about so the numerous guidelines that have different recommendations regarding blood pressure management. My father used to say that a person with one watch knows what time it is. A person with two is never quite sure. And I think it's the same thing with guidelines. We've got different guidelines with conflicting information, so you're never quite sure what's right. But let's talk a little bit about how the KDIGO guidelines for patients with diabetes and chronic kidney disease relate to the others. I think they're fairly consistent in that if you have normal to mild albuminuria, so that A1 category, that having a blood pressure of less than 140/90 is probably okay. But anybody with category A2 or 3, they recommend using the lower blood pressure goal of less than 130/80, which you could interpret as consistent with the ADA guidelines of perhaps using it less than 130/80 for some patients. And I think they have albuminuria as a choice for which might fall under those some patients. Again, ACE inhibitors and ARBs are preferred and should be used really with any degree of proteinuria, even if they're not hypertensive. Moderate to high doses may be necessary. Now, one of the things that you'll see is that there might be some concern about changes in kidney function when you initiate ACE inhibitors or ARBs. And really, it's recommended that you only discontinue if you get a serum potassium more than 5.6, or if there's an acute rise of more than 30% in the serum creatinine after initiation. The concern is those more dramatic changes actually reflect a decrease in filtration pressure that's detrimental long term, whereas the milder increases or the mild increase in potassium might be tolerated and really maybe a good reflection that you're getting good hemodynamic changes as a result of those drugs within the kidney. Many patients will require diuretic in combination to get good blood pressure control. The non-dihydropyridine calcium channel blockers like diltiazem or verapamil can be used as add-ons. There's inconsistent data with some of the dihydropyridine calcium channel blockers and their effects on kidney function. And then some sodium restriction is also important. Glucose control was talked about. Again, try and get as good a glucose control. If patients have more advanced kidney disease, you're less likely to get much benefit from intensive glucose control, so it's better to do it when they have good kidney function, better to protect it then rather than wait till they have more advanced kidney disease. Protein restriction, there's not good data about a true benefit from protein restriction, certainly not less than 0.8 grams per kilogram per day, but certainly high protein diets should be avoided because of the effect on progression of kidney disease. So based on that discussion, what would you like to do here? I think I'm seeing it, right? So we're going to add an enalapril as as the ACE inhibitor on. Again, avoiding nifedipine. Diltiazem might be okay as the next agent. Increasing atenolol, there's no particular advantage for the kidney of beta blockers in slowing progression other than just helping to control blood pressure. Okay. So in case number 9, this patient, enalapril was added. 2 weeks later, he presents back to his physician. Blood pressure is 139/89. Can I hedge the bets anymore? A repeat serum creatinine is 2.3, and that was up from, let me make sure I know my number. I think it was 1.9. And the serum potassium is now 5.2 milliequivalents per liter. So what's your best recommendation for this? Thoughts? I see some A's, I see some B's. It's good. They're more fun when they're controversial. If you look at, I'm going to suggest that the answer is B. If you look at the percentage increase in the serum creatinine, I think again it was 1.9 up to 2.3. It's about a 20% increase. Serum potassium is sort of in that mildly elevated range, but not high enough that we'd want to discontinue it. So I'm going to suggest that at least an attempt should be made to continue to monitor this patient, probably again in 2 weeks, continue the ACE inhibitor. Our blood pressure is not controlled to that less than 130 range, so adding a thiazide diuretic might do 2 things. One, it might increase our blood pressure reduction or lower our blood pressure, and it also might, in combination with the ACE inhibitor, enhance some potassium excretion. So maybe both of those or all of those parameters would improve. At this point, I'm not ready to give up on the ACE inhibitor and switch to diltiazem. Changing from an ACE inhibitor to an angiotensin receptor blocker is not going to be any different in terms of its hemodynamic effects, and again, not increasing the atenolol yet. Okay, here's the domain 2 question, number 10. Let's see where I am. Okay. So one thing that you'll find on the exam is that you may have questions like this where really it focuses on domain 2, but they use the context of nephrology, so it may count as a nephrology question as well. So here's a study that compared the use of an angiotensin receptor blocker alone or in combination with an ACE inhibitor. Acute kidney injury occurred in 8 of 724, or 11% of patients on monotherapy, or 18% of those receiving the combination. So the question is, what is the number of patients needed to harm? So you may have talked about number needed to treat, but now I'm asking you about number needed to harm. Okay, I'm seeing some B's, and a few people looking for their calculator. Okay. So the concept of number needed to harm is the same as number needed to treat. It just depends upon whether your outcome is a bad outcome or a good outcome. So the number needed to treat or number needed to harm is 1 over the change in the absolute risk. If we're talking about number needed to harm, it's 1 over the absolute risk increase. So in this case, the risk went from 11% to 18%, so that's a 7% increase in risk. So if you take 1 divided by 7% as a decibel, 1 over 0.07, you get 14.3. And so you always round up to the next highest number. So in this case, the number needed to harm would be 15, which means that for every 15 people we treated with the combination compared to monotherapy, based on these study results, that you would get 1 additional patient developing acute kidney injury. Okay. Okay. A few people looked like they were still taking notes. So, okay. All right. So let's switch gears a little bit and now talk about talk about dialysis. We'll talk a little bit about renal replacement therapy in general, then we'll talk about some complications related to hemodialysis, and then some related to peritoneal dialysis. So number 11, a 70-year-old man is being assessed for access, vascular access for hemodialysis. Again, he has diabetes and hypertension, otherwise healthy. Sounds funny when I say it out loud. When dialysis accesses, which dialysis access has the lowest rate of complications and the longest lifespan, and therefore is the best to use? Okay. Yeah, I'm seeing. Now, why do I see more answers for this than all the drug-related questions? You know, that's good. But so let's talk about renal replacement therapy. First, indications for it. I use the acronym of the vowels, AEIOU, to help me remember this. And so you're not looking strictly at what a patient's kidney function is, but trying to assess whether they're experiencing some metabolic complication related to that decrease in kidney function. So A standing for acidosis, and really you're looking for an acidosis that's not responsive to some type of alkali therapy. Electrolyte abnormalities, particularly we worry about hyperkalemia and the arrhythmias that could be associated with that, but you may also have patients who have severe hyperphosphatemia that could benefit from renal replacement therapy. Intoxication, more commonly dialysis will be used in an acute situation for those intoxications, but could be beneficial, enhancing drug removal. O standing for fluid overload. So again, edema, particularly pulmonary edema that's not responsive to diuretic therapy, or uremia. Again, not strictly lab values, but complications related to that nitrogen waste, whether that's pericarditis or weight loss. And then we're going to talk about the two primary modes, hemodialysis and peritoneal dialysis, but certainly in this country, hemodialysis is used more commonly. So those of you that guessed D were correct. The AV fistula is the preferred access. Here you're taking artery and vein and sort of forming this anastomosis between them. It takes some time for that to mature, for endothelialization to occur, so that there's adequate blood flow. So you have adequate access to enough blood in order to filter. There's fewer complications associated with it. For patients who have peripheral vascular disease, it may be difficult to create an effective AV fistula, and so a graft is put in place to sort of mimic that. There are more complications. Sometimes they clot more, sometimes can get infected. Catheters can be used for those patients who maybe have acute kidney injury or needing hemodialysis, or just as a temporary measure while you're waiting for one of the others to be available. But again, you worry more about thrombosis as well as infections with the catheters. So our preference is the AV fistula. The Tinkoff catheter is actually the name of the catheter that's used for peritoneal dialysis, so that intra-abdominal catheter. So a patient undergoing long-term hemodialysis experiences hypotension during dialysis. After non-pharmacologic approaches have been maximized, sometimes putting them in Trendelenburg can help. Which medication is best to manage their hypotension? See lots of D's, which is true. Again, hypotension during dialysis is primarily related to excessive fluid removal. So again, changing the rate at which ultrafiltration occurs can do it. can be helpful. Sometimes giving them IV saline boluses to help manage hypotension can be helpful. It is important that you evaluate the patient's dry weight, what your target weight is for them, and sometimes that changes over time. But that can be helpful to make sure that you have a good target if somebody has recurrent hypotension. Midodrine is helpful in preventing hypotension. You give it before dialysis. And there's some other agents that are less well studied. We'll talk about those. Cramps, you give vitamin E, and then there's other complications. Vascular access complications you worry about, both infection, primarily staph as your primary cause, or thrombosis can be a problem, and alteplase can be used to correct that. So of our choices, I think most of you picked midodrine is correct. Levocarnitine has been studied, is not very helpful. Sodium chloride is just not going to give you enough help in the short term. Fludrocortisone is a mineralocorticoid and has been used in other patients who have orthostatic hypotension, but again, for this acute intradialytic hypotension is not going to be helpful. Let's talk about this number 13. Now we have a patient with chronic kidney disease who's on peritoneal dialysis, present with fever, abdominal pain. Also notices that the dialysate fluid is cloudy. There's many white blood cells, primarily neutrophils. We get gram stain in culture. And so the question is, if this patient has peritoneal dialysis-related peritonitis, what is the best empiric therapy? Okay, I see some. I think I see several. Okay, so let's talk about this. So this is often you worry about both gram-positive and gram-negative organisms. Certainly Staph aureus, Staph epi, or strep can occur, but also you see gram-negative rods like E. coli or Pseudomonas. And when you're dealing with empiric therapy, you want to make sure that your therapy covers both gram-positive and gram-negative organisms. We administer this intraperitoneally, and we give something first that covers the gram-positives, and you can use vancomycin or a first-generation cephalosporin, and to cover the gram-negatives, using a third-generation cephalosporin or an aminoglycoside. So the guidelines actually of these choices recommend cefazolin, ceftazidime intraperitoneally. I particularly even put this in because that's one of those things that sort of on the surface looks wrong, combining two cephalosporins, but we're doing it in this unique situation, intraperitoneal administration to cover initial therapy for gram-positive and gram-negative organisms. A and C we're not using because unlike patients who might develop peritonitis associated with ascites and liver disease, you don't need anaerobic coverage, so we don't need the metronidazole or clindamycin. C certainly doesn't give, C and D don't give us good gram-negative coverage, so neither of those really are a choice. So B is our answer. So the next two cases are going to address the complications associated with chronic kidney disease. This one has quite a bit of detail in it. So we have a 60-year-old person with end-stage renal disease for a long time, is on hemodialysis, is getting epoetin alpha, 14,000 units IV 3 times a week at dialysis, and let's see where to go. Is also on calcium acetate. Current hemoglobin is 10.2 grams per deciliter. Phosphorus is 7.8. Transferrin saturation is 32%. Has normal red blood cell indices and is currently afebrile. So this patient has relative erythropoietin resistance. Which of these is most likely causing it in this patient? So they're on high doses of EPO and their hemoglobin is still around 10. Okay, well, let's talk about this a little bit. So certainly patients with chronic kidney disease can develop anemia. It often can occur as early as stage 3 or 3A kidney disease. And decreased erythropoietin production is the primary mechanism, but there's other things that can go on. The lifespan of the red blood cell is shorter. People who are on dialysis may actually be losing blood through that way. Iron deficiency is fairly common in these patients, particularly if you're restricting their protein intake. And renal osteodystrophy also contributes to it. And there's a number of reasons why we might want to try and treat chronic kidney disease. So when do you first evaluate a patient for anemia in chronic kidney disease? First, start thinking about it being related to their kidney disease if their GFR is less than 60. And you think about anemia, hemoglobin less than 13 in men or less than 12 in women. How often should you evaluate the hemoglobin hematocrit? On stage 3, do it at least every year. Stage 4 and 5, as long as they're not on dialysis, probably every 6 months. And if they are on dialysis, at least every 3 months. They usually, if it's related to kidney disease, they usually have a normocytic anemia, so their MCV will be normal. Reticulocyte count, which reflects how well the bone marrow is producing new red cells, is usually low. It's important to look at their iron studies. Where the ferritin measures sort of their overall iron stores, the transferrin saturation can be helpful to look at. You can calculate that by taking the serum iron divided by the TIBC, multiplying it by 100 to get a percent. Patients may have adequate overall stores but have a sort of functional iron deficiency if their transferrin saturation is low. You also worry about them being vitamin deficient, so you might look at B12 and folate levels, and certainly look for other causes of blood loss, so looking at the stool guaiac can also be helpful in your evaluation. So this algorithm, which is on page 282 of the handout, is designed to help you sort of think through this. When you look at all those studies and first try and evaluate whether they're iron deficient. If they are iron deficient, then using oral or parenteral iron therapy. If somebody's pre-dialysis, you might be able to get by with oral therapy. The worse their kidney function, the more likely they are to need parenteral iron therapy. If you give them iron supplementation, you correct their anemia, everybody wins, and then you continue them on iron and continue to monitor them. If you don't correct the anemia, meaning that the hemoglobin is less than 10, then you think about adding erythropoietin stimulating agents, ESAs, to their iron therapy. While you do that, you monitor their hemoglobin every 2 to 4 weeks. If it's not increasing by at least 1 gram per deciliter within 4 weeks, then you can increase the dose, again, assuming they have adequate iron stores. If it increases too quickly, meaning more than 1 gram in 2 weeks, then you want to decrease the dose about 25%. But you want to keep it less than 11. Again, you've got a couple of choices. The approach to treatment of anemia and chronic kidney disease has changed a little bit over the years. The goal is really to use the lowest dose in order to prevent transfusions. That's really what the lowest dose to prevent transfusions. In non-dialysis patients, you want to hold or reduce the dose if the hemoglobin is greater than 10. In dialysis patients, you can go as high as 11. KDIGO suggests the upper limit's 11.5. But at no time do you want it to go greater than 13. So depending upon how quickly it's rising and to what level might help guide you on whether you're going to just reduce the dose or to hold it. Again, monitoring hemoglobin every 2 to 4 weeks during initiation and dose titration, monthly on dialysis patients once they're stable, every 3 months in non-dialysis patients. Remember to monitor the blood pressure because that can go up for these patients, and look at their iron stores. Here's our goals. Ferritin you want high, above 500, and transferrin saturation above 30%. I've also seen these numbers change a little bit over the years, but these are sort of the current recommendations. Iron deficiency is the most common reason why people fail erythropoietin therapy or become resistant and require higher doses. That's why I emphasize sort of assessing that at first. But there's a number of other things. Chronic blood loss, again, can make it more difficult to correct. Osteitis fibrosa, again, related to the osteodystrophy. Hyperparathyroidism. Aluminum toxicity, so aluminum can impair iron incorporation into heme, so they may actually develop a microcytic anemia. So if you see that, think of that. And then folate and B12 deficiency can actually contribute to a macrocytic anemia. And there may be other things as well. Most patients who are with chronic kidney disease are not going to be able to take in enough oral iron in order to meet their requirements. So for many, you're going to have to use parenteral therapy. So, and that often means high doses. And there's a number of products available. This is table 6 in your handout. Point out 2 things. One, notice that iron dextran is the one that requires the test dose. But remember, any of these, patients can experience hypersensitivity reactions, and so monitoring patients for at least 30 minutes after administration is complete is needed. And they have black box warnings associated with that. So our answer in this patient, although iron deficiency is the most common, they had adequate iron stores, so hyperparathyroidism is the most likely. Infection can make them less likely to respond, and phenytoin therapy sometimes can cause it, but not here. Let's look at this case. This focuses on the mineral bone disease. Best approach to managing hyperparathyroidism in this patient. Remind you the patient had a phosphate of 7.8. We had calcium values, and their parathyroid hormone level was 800. The light's yellow, so I'm going to press forward so we talk about this. Patients can develop mineral bone disease when the GFR falls to less than 60. This can result in either renal osteodystrophy or vascular calcifications. And there's a number of metabolic causes, high phosphate, low vitamin D, low calcium, high PTH, that can all contribute to that. Tables 7 and 8 really guide you on monitoring these patients. So looking at calcium, phosphate, PTH, alkaline phosphatase to reflect bone turnover, and 25-hydroxy vitamin D to see if there's any nutritional vitamin D deficiency. Again, for most patients, we're trying to normalize our values. Notice if patients are on dialysis for phosphate and PTH, we may tolerate slightly higher than normal values. Phosphate binders are going to be sort of your first step here. Avoid aluminum-containing phosphate binders. If you have to use them for somebody who has severe hyperphosphatemia, really limit that use to less than 30 days. Again, most times it's not needed. Calcium-containing phosphate binders are often used as the initial. Calcium carbonate is relatively inexpensive and fairly easy to get and to use. So for stage 3 and 4 CKD, that may be okay. Calcium acetate probably binds phosphate better. There's less calcium given, so hypercalcemia is less common. You want to look at the total calcium intake and try, if you consider about 500 milligrams comes from diet, try and not give them more than 1,500 milligrams of elemental calcium. Sevelamer and lanthanum are both good phosphate binders, particularly if you're concerned about the calcium load that a patient is getting. Vitamin D analogs, you can, if it's a nutritional deficiency, you can use ergocalciferol or cholecalciferol. More advanced renal disease, you want to use something active. Calcitriol is fully active, is beneficial. Paracalcitol will be better for somebody who has hypercalcemia because it causes less calcium absorption. Cinacalcet is really used for those patients who have hypercalcemia. So the answer here is change from calcium acetate to sevelamer. The one thing, if you just look at the calcium level itself is okay, but because of the low albumin, their corrected calcium is actually in the high range, so you need to pay attention to that. So because the corrected calcium is high, we want to avoid calcium-containing agents. We can't use the vitamin D analogs, so using cinacalcet is really your choice. And the answer page has a more detailed explanation. The last case, and I'm almost out of time, is really trying to help you look at drug dosing in renal dysfunction. Here we have a patient with phenytoin. Their level is 5 micrograms per ml, so it's below the usual therapeutic range, but their albumin is 3. And you can look at adjusted concentrations that take into account both the decreased albumin concentration and the decreased binding to albumin that occurs in patients with renal failure. So if you correct or adjust this patient's phenytoin concentration, it actually falls within the usual therapeutic range, and since their seizures are controlled, we would not change therapy. So no dosage adjustment is needed at that time. And I am 48 seconds too long, so I will be around during the break if you have any questions.